You recorded on my computer. Okay, amazing. Right, so with that, let me get started with today's presentation. So I am talking today about the Inflation Reduction Act. For some of you, I may have already hinted at this last year, but the real impact that we're going to see is happening next year in 2025. I'm not able to quote or talk to you about plan-specific information, not until October 1st. However, this is a policy that went into effect that is already, you can look them up, you can look it up online. So I'm able to talk to you about what we're expecting the impact of this policy to be so that you are ahead of the game and you're better prepared. So for most of you, I am your insurance agent, and I'm proud of that, and I hope that I've done a good job. This was something I'm doing just for my clients. This was not, I did not advertise this to the public. So in case you didn't know what being a licensed insurance agent means, that means that I'm certified, I'm trained every single year. I spend probably more than, it seems like more than 80 hours a year certifying with most carriers. This year I certified with 16 different carriers. And to give you an idea, attorneys, nurses, CPAs, what you see here, they only spend an average of 20 hours a year educating themselves on their lines of business compared to Medicare. So that's how confusing and how intense Medicare products are. Every year I have to pass an annual exam, which covers fraud, waste, and abuse as well. And I am trained to use Medicare.gov. However, most of you, if I've ever met with you and you've seen me share my screen, I use another site that kind of bounces off of Medicare.gov to quote and enroll you. Now, with being a licensed insurance agent, my promise to you is that you will get knowledgeable and personalized attention from me. I will educate you like I'm doing today on all the Medicare plan options. We will review your plan annually and year-round if you have questions. I'm here for you as well. So what we're going to cover today is just a quick overview of the Medicare basics. Most of you are already on Medicare, so I'm not going to dig into it too much. We're going to talk about the Inflation Reduction Act. We're going to talk about what's improving, what the impact is going to be for you, what you can do, and a quick overview of Medicare in general. So let's just go through the quick Medicare basics. Most of you, all of you on here have Medicare Part A and Part B. Otherwise, I wouldn't be your broker. I wouldn't have been able to help you. So Part A is just hospital coverage and Part B is medical coverage. You have two options to fill the gaps of Medicare. And again, I'm not going to go into detail of it, but you know what you have. You either have a Medicare Advantage, which is the option 5 in this image, and that includes your prescription drug coverage. It's one plan that covers your hospital, your medical, and your drugs. Or you have what you see on the left, which is option 3 and 4. That's going to be your Medicare supplement plan. That could be your Plan G, Plan F, Plan N. And separately, you have a prescription drug plan. So that could be through WellCare or through Aetna or United or Humana. So that would be your prescription drug plan. That's going to be our focus today. Whether you have an Advantage plan or a standalone prescription drug plan, the Inflation Reduction Act will affect you next year. So this is this year's pricing. Medicare has not yet announced 2025 pricing. Hopefully when you and I meet next month, I'll have these numbers, so I'll be able to update you better. But if you only had Part A and Part B, you would be responsible for some of these deductibles and co-payments. The only thing that we know for sure, well, I'll get to that in a second, but the Part B cost that you're paying per month is either coming out of your Social Security, $174.70, or it's being paid, you pay them directly. And some of you might have a higher cost if you have a higher income. Also, there's a Medicare Part B deductible. So if you're on a Medicare supplement plan, like a Plan G, you might be responsible for that first $240 deductible. If you're on an Advantage plan, you probably don't have a deductible. So Part C is the Medicare Advantage. That's the option 5 from the previous screen. And again, it encompasses everything, Part A, Part B, and generally it also covers Part D. The Medicare Advantage plan, again, in general, has very low cost to no cost, and usually has no or very low deductible, if any, at all. With the Part D plan, this year you had a $545 max deductible. Some of you may have had a lower deductible. If you're on a standalone prescription drug plan, next year the max deductible is going to be $590. And I'll talk about that again in a little bit. And you also have a monthly premium on this plan. The lower the premium, very likely the higher deductible you have. The higher premium, very likely lower to no deductible you might have. And the Medicare supplement keeps Medicare primary. So you can see any doctor that takes Medicare. You pay more for that flexibility in comparison for the Medicare Advantage plan, but you generally have low to no copays once you use your drug coverage. I'm sorry, your medical coverage. So that's just a quick overview. You all know what you have. Everyone on here is individually may have a different plan. So I don't want to go into details of every single person's plan. You and I will do that during our one-on-one meeting. This presentation is really more about the Inflation Reduction Act, just to give you a heads up again on the changes. So why did the Inflation Reduction Act even come about? It's mainly because of these statistics. 82% of adults think that the cost of prescription drugs is unreasonable. And 30% say that they have not taken a prescription because of the cost. And even about the same amount of adults said that it was difficult for them to even afford it. And I've spoken to some people who have said, look, my doctor recommended this prescription, I just can't afford it, and I'm not going to fill it. So the Inflation Reduction Act came about to make a change on this, to make sure that seniors wouldn't have to decide between filling a prescription that could be life-saving versus paying for groceries. So they came about with the Inflation Reduction Act. It passed in 2022. The Inflation Reduction Act was not just about Medicare. It was about a ton of other unrelated to Medicare things, but Medicare did have a portion of this Inflation Reduction Act. What it's meant to do is increase access to treatments. That would fall under Part B as in boy. It also aims to provide affordable coverage for prescriptions and make it more sustainable in the long run. So reducing the costs to Medicare, which I'll show you as well, so that the Medicare program as a whole will hopefully live a bit longer. We're going to discuss these 4 main changes. What's improving in Part D over time, what's going to happen in the future in terms of price negotiations, what are the rebates that are being affected through the Inflation Reduction Act, and any changes to Medicare Part B, which actually started in 2023. So this is a really cool timeline. If you remember, some of you in 2022, so prior to the Inflation Reduction Act, would call and say, hey, why do I have to pay for the shingles vaccine? Or why is there a copay for shingles? Why isn't my, insurance covering it? So prior to 2022 or 23, shingles was one of those vaccines that Medicare just didn't cover. So come the Inflation Reduction Act, that changed. Vaccines are now covered without copays. So that was a really good improvement, as well as we saw insulin costs go down to $35. Regarding insulin, when it says insulin here, it's referring to insulins that come in a vial like Humalog, Novolog. It's not talking about things like Jardiance or Ozempic. It's talking about specific insulins that usually you need to refrigerate. In 2024, they've expanded the Extra Help program. So for those that think they might qualify based on having a lower income, Extra Help is a program designed to keep your drug costs low. And sometimes it even covers the premium for your prescription drug plan. And it usually puts a max on copays for even brand name prescriptions. This is not Medi-Cal or Medicaid. This is a program designed specifically through the federal government, sometimes referred to as low income subsidy or extra help. If you think you might qualify for this program, we can discuss it one-on-one. I can go through the income levels with you, the thresholds, and we can even help you apply, because it could tremendously save you on cost even as soon as this year if you think you qualify. And it doesn't hurt to try, because there's no, either they approve you or they deny you. There's no negative impact on you. Now in 2025, some of the improvements that you'll be looking at is a $2,000 annual cap on prescription drugs. That means your copays that you're paying, not your premiums, but your copays will be capped out at $2,000. You're also initiating a payment program. This payment program, if you are on a heavy, a high cost prescription, you're not going to have to pay the $2,000 in January, for example, or even $500. You could spread that out over a year, the entire 12-month. And we'll talk a little bit more about that. They're redesigning the Part D levels as a whole, and they're implementing a manufacturer's discount program. So we're going to dig a little bit deeper into each one of these. Out of pocket for next year, and again, this is whether you are on a standalone drug plan, for example, like many of you might be on the WellCare Value Script plan, Aetna Silver Script. Those are going to be your standalone drug plans. Those are different than your medical plan. And some of you might be on a Medicare Advantage prescription drug plan. So it's your same, whether it's maybe Alignment, which covers your Part D, or Scan, or Blue Shield. It would just be the same card that you go to the doctor with, that you go to the pharmacy with. That would be a Medicare Advantage plan. So this applies to both, wherever you get your drug coverage. Next year, your out-of-pocket threshold is $2,000. That's it, not a penny more. If you want, you can enroll in a prescription payment plan. And what's going to happen this month is, if you're on a high-cost prescription, before October 1st, the plan that you have will be emailing you a notice saying you may want to enter the prescription payment plan because you're on Eliquis or you're on Repatha, whatever that prescription is that's expensive. They know, because they could see your formulary, and they're going to reach out to you and say, you might want to join the payment plan so that you can pay it over time next year. It's optional. You don't have to. So here's a little bit more about that prescription payment plan. It helps you manage the cost over the course of the year. But there's a few things that is very important for you to remember. Number one, when you pick up your prescription, you're not going to pay anything. You're going to get a bill from your insurance. So again, whatever your Part D insurance is, they will send you a bill. And that bill might fluctuate throughout the year. So in January, you might be charged one amount because maybe you have a deductible to meet. And then in February, that might drop a little bit. But then maybe in March, they're adding other prescriptions costs to, because once you enroll, all your drugs are enrolled in the prescription drug plan. You can't say, I only want this drug and I'll just pay for the other drug at the pharmacy. No, you either enroll in all your prescriptions are included or none are. So that's something important. If you have a deductible on your plan, you're going to have to meet that deductible first, and then the copays will apply. Again, that deductible, though, can be spread out along in the Medicare prescription payment plan, because let's say you have a $590 deductible and your prescription costs retail is $600. So you can have that paid over time. So you don't have to have the 600. It's just the way that you pay it, the deductible will be applied first. And that's why it says here the monthly bill may fluctuate. You can opt out at any time, but you still have to pay what's owed. So if you decide, okay, I really don't like getting these bills anymore, I'm just moving forward, I don't want to be part of this plan, that's fine, but you still have to make up the bills that will be coming to you. They're still going to bill you for that. The same thing, actually, before I get into this slide, the same thing holds true if you change your drug plan. So if you switch your insurance halfway through the year and you were on a payment plan with one carrier, that original carrier is still going to bill you. You still have to pay the bill from whoever set you up with the payment plan. And then the new insurance may not bill you for that. They'll bill you for any future prescriptions that you pick up. So I know that part can be a little bit confusing, but just know if we ever switch your insurance halfway through the year or whenever, then that's something I'll remind you of if you were on a payment plan. Okay, so up until this year, 2024, there were 4 phases to your drug coverage. And again, regardless of whether you're on a standalone drug or a Medicare Advantage, you had 4 phases. The first phase was your deductible phase. If you had a deductible, you had to meet it. If you didn't have a deductible, then you basically met it already and you moved into phase 2. Phase 2 for 2025 is where you pay your copays. So let's say you have a $5 copay or a $10 copay. Remember, your max is going to be $2,000. And that also includes any manufacturer's discounts that are being applied as well. So your out of pocket might actually be a lot less than $2,000. And that's something that you and I will review again. When we meet one-on-one and I have all your prescriptions, I'll be able to tell you, okay, January, this is what your cost will be. February, this is what your cost will be. And then when you're going to hit that max. This year, you had a coverage gap or a donut hole. If you hit that coverage gap, you are now paying 25% of the cost. That is being eliminated next year. So it's just that $2,000 max. That's it. Once you hit it, the remainder of the year, you move to catastrophic and you're at 0 cost for the rest of the year. This year, if you move to catastrophic, you're done. You're not paying anything for the remainder of the year. But this year, you had to get through the donut hole. So that this coverage gap phase, this third phase, even though here it says phase 3 is catastrophic, phase 3 was actually, for next year, phase 3 is catastrophic. For this year, phase 3 was coverage gap. The coverage gap is ending, so you won't have to pay that 25%. And it's being replaced with a manufacturer's discount program. The manufacturer's discount program, the way it works is manufacturers are going to be, if they want the drug covered by Medicare Part D, they are required to participate in the discount program. So they will be paying 10% discount is what their cost share is, meaning what the manufacturer pays is a 10% discount. That's already going to be applied. On the next slide, I'll be able to show you what that looks like. During the catastrophic phase, they're going to have a 20% discount. And then I'll show you who's paying for that 80%. This is a very confusing slide. So I'm going to break it down for you because it's really important for you to understand the next part of what's happening with why we're going to see a tremendous amount of changes next year. Up until this year, if you look at 23 and 24, and this is for brand name drugs, what you'll notice is the manufacturer, which is the green amount, they were responsible for 70% of the cost of your prescriptions in the coverage gap. Well, remember, the coverage gap is now being eliminated. So what you see here is that in 2025, the cost of your brand name prescriptions is shifting away from the manufacturers, mostly onto Part D plans. So whether that's your Medicare Advantage or whether it's your standalone drug plan, you can see that big shift that in catastrophic phase especially, the plan is now responsible for 60% of the cost, whereas up until this year, they were only responsible for 20%. And that's when it gets very expensive. When you hit the catastrophic level, I mean, once you're out of pocket 2000, now the insurance plan is on the hook. The manufacturers are only responsible for 20% and Medicare even less. So you can see this year, Medicare was responsible for 80% of the cost when you hit catastrophic. However, next year they're only responsible for 20%. Now for generic, I'm going to show you on the next slide. Look at that. For generic, Medicare drops its responsibility from 80% down to 40%, half. And now the insurance carriers are responsible for a lot more of the cost of your prescriptions. This is extremely important to understand because what we're seeing is if you were on a plan that had no deductible or you were on a plan that had very low premium, we're seeing that next year the cost of your premium is going to go up at minimum double or triple the cost. And it's because of this. It's because the insurance carriers are basically saying, look, if we're going to pay more for the cost of the prescriptions, we got to make up that money somewhere. And this is why, for the main reason why I wanted you to be able to see why this is happening. It's because of the Inflation Reduction Act. Yes, it's great that your out of pocket is being capped at 2000, but you know that the insurance company is going to try to make it up somewhere else because they're not for profit. Okay. Changes to Medicare Part B. So we discussed this already. Reducing the cost of insulin, that's going to continue. Improving access to more affordable biosimilar drugs, which are drugs made from natural resources. So that's great. I actually heard from a client of mine who said that she was on a thyroid medication that generally was not being covered, Armothyroid, and the plan that she's on is now covering it. So that would be something like a biosimilar medication. In terms of the inflation rebates, what's happening is because of that shift that I showed you on the last slide, where now the insurance carriers are more responsible for the cost, the rebates are going to Medicare, meaning Medicare is saving on cost since the drug companies, the carriers are going to be covering more of it. If the drug companies charge more, increase their prices more for specific drugs, they're going to be penalized as well. And then Medicare drug price negotiations. So I'm going to show you on the next slide. They have already begun negotiating prices on certain drugs. It's not going to start until 2026. But remember, your max out of pocket next year is $2,000. So even if they don't negotiate for 2025 on a prescription that you're taking currently, just remember that your max is still going to be probably less than $2,000. So these are the drugs for 2026 that are being negotiated, and these are the prices that they are hoping to negotiate on. A lot of my clients are on Januvia, Jardiance, Xarelto, and Eliquis has been a big one. So you can see that they're negotiating the price down, and it shows you the discount on the side, but it does not mean that it's free. And we still don't know what your cost will be. We just know that this is the discounted rate. So just kind of keep that in mind. And again, I'm happy to share this with you guys because I know it's a lot of information. All right. So what are all these changes? How are all these changes going to impact you and your Medicare coverage? So a lot of this I mentioned already, but it bears repeating. Again, the max for you out of pocket is going to be capped at $2,000. Your monthly payments, you have a monthly payment plan, which will allow you to spread out the cost of your prescriptions over time. Previously, you may have not been able to take a brand name drug that you wanted. Now you might be able to, it might be more affordable. However, you just remember, it still has to be covered by the insurance plan. Manufacturers are going to be instituting discounts and rebate plans to help reduce the cost of the prescriptions. However, and they are going to be limited to price increasing. Your medication choices should remain the same, as no drug is excluded. However, that doesn't mean that every single drug is covered by your Part D plan. So they still have the option to choose a generic coverage over brand name. They can still say, well, we're not going to cover the brand name. We're only going to cover the generic. So some things that you need to be concerned about. Number one, if you want to choose the Medicare prescription payment plan, definitely figure that out at the beginning of the year because it just will help you for the remainder of the year. But if you think you qualify, or if you're already on extra help or that low income subsidy, you probably don't want to take part in the payment plan because again, your costs are going to be really low. Also, generally what we've been recommending is if you're on a drug that's going to cost you $400 or more, you might want to consider being on the payment plan. If you can afford to pay the copay, then you may just want to pay the copay and not deal with getting billed every month by the carrier and having that fluctuate again, depending on your other prescriptions. As I mentioned before, if you are on an expensive medication, your plan is required to outreach to you to let you know that you might qualify for the payment plan. So definitely check your mail for letters from your insurance plan that you have right now. Some drugs that are excluded from the Medicare prescription plan, again, drugs that are not covered. So we still want to make sure that your drug is covered next year on your plan. And Part B drugs. Part B drugs are prescriptions that like injections, chemotherapy, things that you get from the doctor's office or from a facility, not necessarily from the pharmacy. So any Part B medications are not going to be part of the payment plan. The $2,000 cap does not apply to anything Part B related as well. So it's only, again, on prescriptions that are covered by your plan that are picked up at the pharmacy or through a mail order. So what that means is if the prescription is not covered, it won't apply. If you have to pay out of pocket for the prescription, it's not going to go towards that 2,000. So if you're using GoodRx or Single Care or Cost Plus drugs, or you're getting your prescription from Canada, none of that is going to go towards the 2,000. Only what you actually pay that's covered by your drug plan will go towards the 2,000. Once you've met your out-of-pocket cost, one second, let me read this. Once you incur a Part D out-of-pocket cost, the payment plan will apply all of your covered drugs and billed monthly, meaning you can't pick and choose which prescriptions you want to include in the payment plan. And Part D plans will continue to bill you for any amounts owed. So even if you're going there to the pharmacy and you're paying zero, you're going to get a bill from the carrier for whatever you owe added to the monthly payment. You can cancel participation, but you still have to pay the original plan. So Part D plans also can choose not to cover certain drugs. Notice any applicable changes and get assistance from your doctor about alternatives. And they can also choose to, like, they might say in January we'll cover this drug, and then all of a sudden a generic comes out in March, and they can choose not to cover that generic brand name anymore. So that's something that could change at any time of the year. So the new law has prevented Part D base beneficiary premiums from increasing more than 6%. This has been a very misleading line that we've seen in the Inflation Reduction Act because it made us believe that, wow, this is great. You're going to limit the $2,000, you're going to put a limit to the max out of pocket to 2,000, and you can't increase the premiums more than 6%. That's not true. What it relates to is, you see that word base? That's the key. There is something called a base premium. It's a national rate. The national rate is what Medicare decides if somebody has a penalty because they didn't enroll in Part D on time. They have to pay a percentage of the base national rate. That is not your monthly premium. Your monthly premium can go up 100 times, and some have between this year and next year. So what this means is if you have a Part D penalty, the base rate can't go up more than 6%. I know that part can be confusing, but just know, again, when we meet one-on-one, we'll talk about your specific plan and how that's changing. The plan sponsor, meaning the carrier, their liability will increase in the catastrophic phase. So once you're at zero, once you've hit your max and you have no more out of pocket on your covered prescriptions, you might see a reduction in the plan service. And that's again why we're seeing premiums increasing so drastically. The other thing that is happening is the definition of creditable coverage for prescription drugs has been redefined, meaning it used to be that, max out of pocket was $8,000. That include manufacturers' discounts and all these other parts, including your out of pocket. They went from $8,000 down to $2,000. That means the credible coverage has changed. So for those people who were still working and they were on a group, or they're on a group coverage this year, next year, if they look at their group plan might not be a $2,000 limit. It might have more. So that has affected the way that we consider plans credible or not credible, if you have to take Medicare or not take Medicare. For most of you, you're already on Medicare, so this doesn't relate to you. But if you have any friends that are currently working and on group coverage, this caused tremendous chaos in the group insurance world to the point that they complained so much because they said this is going to affect hundreds of thousands of people who are working past the age of 65. You can't just all of a sudden change it and then think that everyone is going to read their mail and know that their plan is not credible anymore. So CMS actually put a pause on it and they said, okay, you might have a good point. We're going to pause it for group insurance until next year, 2026. So 2 years. But just know if you know, I don't think it relates to anybody on this call today, but if you know someone who is still working, starting between 25 and 26, they're going to definitely want to make sure that their plan is still deemed credible. All right, so the fun part, what can you do about all this? Please remember that your healthcare needs are your priority. That line cannot be understated. And the reason is that many of you and many people in general, including me, feel a commitment to a specific plan just because we've been with them for so long and it's comfortable and we're familiar. Like we have ABC insurance and we've been with ABC insurance for 10 years. And it's almost like we feel this, relationship. However, you need to know that your healthcare is your priority, not the label on the card that you hold. If that carrier is still going to be good for next year, amazing. Just, I hate making change. Everyone hates change. But if that plan is changing on you, you need to take priority over your health care. You need to decide what is best for you, not the carrier. They make those changes without asking you permission. So what we're going to do is review your current plan. Please make sure to keep a list of all your current medications, even medications that you maybe take once or twice a year. Every year, starting this month in September, they are required before October 1st to send you a notice. It's called the Annual Notice of Change, or ANOC for short, ANOC. The Annual Notice of Change is more important than ever this year because it will show you how your plan is changing between this year and next year. And that's what we review during the annual enrollment period. Be also wary of unsolicited marketing, even from your own insurance carrier. So I can tell you now that there are insurance companies, including the ones that you probably have in your wallet right now, that are already saying, well, we're going to try to convince our clients who are on a Part D plan to move to a Medicare Advantage. And they're allowed to call you because you're their client. So please just be aware. I've had too many clients get their plans switched over the phone because they were enticed by this or enticed by that, not realizing that, well, now they can't see that doctor that they really wanted to see, or they lost the flexibility of the plan that they really wanted. The other thing I want you to know is some plans have decided to completely terminate. They just decided we're done. We don't want to offer this product anymore. And that's why the annual notice of change is very important too, because if your plan is terminating and you're not going to have coverage next year, we want to make sure that you're put onto the right plan. This is a QR code to the new law. This is through CMS directly, where you can read and learn more about it. If you find anything interesting, you're welcome to share with me. I love getting emails from you, text messages. However, but I think that I covered the most important points during this presentation. So hopefully you grabbed that. There's some other resources available to you. Definitely, you can go to Medicare.gov, you call 1-800-Medicare. There's also the National Council on Aging and SHIP, State Health Insurance Assistance Program. However, please know none of these sites, except for Medicare, Medicare will help you enroll, but then that would take me away as your broker. You're welcome to go to these resources, try to navigate them yourself. I never tell anyone not to educate themselves, absolutely. But if you want me to remain your broker, you really should reach out to me. During this presentation, I cited a lot of different sources of information. Again, you're welcome to take a screenshot of this. I'm happy to send this to you too if you just want some reading material. But all of this was found through different sources, all about the Inflation Reduction Act. Okay. I don't think I need to convince any of you guys that it's overwhelming. But I want to say one thing. I did hint to plans terminating. Um, Again, I'm not allowed to talk about it until October 1st, which specific plans. You will receive the annual notice of change, so you'll know if it's you or not. Either way, you should book a time on my calendar to review your plans. But I also want to make you aware of a couple other things. Number one, some plans have decided that they're not going to pay brokers commission anymore. They just said, we're done. We think that we can do it on our own. There are hundreds of thousands of Medicare licensed brokers throughout the country. So I can tell you that me personally will always do whatever is right by my client. However, if that means that you have to be placed on a plan that I cannot represent, that means that I cannot enroll you. I can't take the risk of putting you on a plan that if something happens down the line, I can't even call them to find out what's going on. I don't charge anything. I don't charge you guys for my services. So the only way I get compensated is through a commission. So just know that when we sit down and talk, I'm going to let you know if the plan that I recommend is commissionable to me or not. I will always give you an option for the alternative, a plan that does pay me. However, if you want to enroll on a plan, if it's better suited for you, then you're going to have to do that on your own. So I just want to give you the heads up on that. The other thing too is I will be sending out a link to you next week at some point before the end of the week to update your prescription list in my system. It will help me so that when we do sit down, I will already have all your current drugs, and it'll make the process a lot smoother. Also, I'm going to send you something called a scope of appointment form, which many of you have already filled out in the past, but we are required to renew that annually. So again, I'm going to send out an email explaining it all to you, but I just want you to be aware of those things. So a link to update your prescriptions and a scope of appointment form, and also a link to book time on my calendar. What we're going to review are all these options that you have. If you're still working, which I don't think any of you are on employer plan, but if you are, we would review your employer plan, compare it to Medicare. You can stay on original Medicare if you want. However, I don't recommend staying on it without a secondary plan, and that would be either Medicare Advantage HMO or PPO, which is a very good alternative to the ones that are on a Medicare supplement who maybe it's become unaffordable. So we'll go over all of these different options. You guys know what it's like to work with me. You know how, I think I had this slide at the beginning too. You know the personalized attention that I give you and the care. And now, especially having my son on board, it's just an additional branch of service that we can offer you. If you get a call from Simpler Horizons or anyone saying Simpler Horizons, please know that's my company. So sometimes people just know Elka, which is great because I love knowing you. But if it's Simpler Horizons, that's also Elka. And if you need me specifically, ask for me and you'll get on my calendar. If for whatever reason there's a situation that, let's say, Michael can't handle or somebody in-house can't handle. I went through a lot of information today. Please know everybody is different. Everybody has a different situation. It's not one size fits all. It's not one plan fits all. So we meet one-on-one to review your plan benefits each year for that reason. Um, I did get a new phone number. All my phone numbers, my existing phone numbers that you have for me still work. They're all working phone numbers. But this particular phone number is great because if you call it, it goes straight into my site. So I can pull up your information right away. If you want, you can write that down. I will, again, it'll be in my email. So you are welcome to just look at the email that I send you. And as always, I have a link to my calendar and it's right here. So if you are comfortable scanning that QR code, you can already book time. I would recommend after October 15th, because at that point I can actually quote you and enroll you on a plan if that's what we end up doing. Like I said, best situation is when we meet and I say, just stay with what you've got. It's the best plan. And that's probably going to happen often enough. But in case it's not, then October 1st, I can already quote you, but October 15th, I can actually quote and enroll you. And remember that annual enrollment ends December 7th. So we have a short window of time. And in all honesty, I've only allowed Tuesday, Wednesday, and Thursdays for my reviews. So please scan this, book a time with me already so that you're not being pushed, out till the end of November or the beginning of December. And with that, I hope you enjoyed that presentation.